Bismillahirrahmanirrahim. Assalamu alaikum and good morning, good afternoon, and good evening, wherever our participants may be. So this is the second day of our two-day hybrid workshop. And today our focus is going to be on genetics and genomic challenges. However, more than the science, we are looking at the social aspects of genetics and genomics on not only the population, but also on the health professionals and scientists. So I'll just run through the program, and before I hand over to the chair after I've introduced her. So what we will start off with is a keynote address by Dr. Salman Kirmani, dealing with looking at consanguinity in the context of the Pakistani society. He will be followed by 3 talks in the cluster. The first talk will be by Dr. Emmanuel Truling on human genome editing, and she will be looking at the WHO framework for governance. This will be followed by Dr. Ms. Fiza Akbar, who will be talking about advances in genomics and challenges in genetic counseling in Pakistan. Being one of the very few genetic counselors in Pakistan, she will really bring a very different perspective. Then we will have Ms. Swaleha Shikhani, who will talk about genome editing and based on perspectives from Pakistan, based on a ongoing research. We will have a panel discussion, which is going to be moderated by Dr. Natasha Anwar, in which we will take questions framed at all the 3 talks. The keynote address will have its own question and answers, either during, as Dr. Salman has said, during the talk itself, you can pose questions, or after the talk. However, for the the cluster of 3 talks that are going to be on genomic challenges, we will have the full half hour moderated by Dr. Natasha. You should send, the online participants should send their questions or comments in the chat box only, the chat box. We will keep compiling them and put them to the respective speakers or the panel as you would wish. We will then end with closing remarks from Dr. Araish Rashidian on behalf of EMRO WHO, and that's when we'll end the conference. So I will now introduce to you the chair for the day, who will lead the session and moderate the session. So it is my pleasure to introduce Professor Niveen Abu-Rmeileh. Dr. Remeleh is a professor of epidemiology and public health at the Institute of Community and Public Health at Birzeit University, Palestine. She is the coordinator of Women's Health Unit and Evidence Synthesis Center at her institute. She is a board member of the Global Implementation Society and also a member of the Eastern Mediterranean Advisory Committee on Health Research, the ACHR. She is also a member of the WHO Eastern Mediterranean Research Ethics Committee, of which I happen to be a co-member with her. She has led national research, regional and international research, and published more than 240 scientific papers. Her areas of expertise include advanced epidemiological and statistical methods, implementational research, non-communicable disease, and maternal and child health. I can now hand over to Dr. Niveen with just the hope that one day we will have her physically present at CBEC leading the sessions in Karachi. But inshallah, till then, over to you virtually, Dr. Niveen.
Thank you very much, Dr. Amer, and it's my pleasure to be attending this workshop. Yesterday, it was an amazing one, and I'm looking forward to an interesting discussion today. So we will not take much time, and we will be punctual and as strict to the time as we can. It's my pleasure to introduce our keynote presenters, Dr. Salman Kirmani, who is a medical geneticist and pediatric endocrinologist associated with Aga Khan University as an associate professor of pediatrics and medicine and chair division of women and child health. He got his MD from Doon Medical College, Karachi, followed by residency and fellowship from Mayo School of Graduate Medical Education, Mayo Clinic. He is certified by the American Board of Medical Genetics and American Board of Pediatrics. He was a faculty member at the Mayo Clinic till he returned to Pakistan to join Aga Khan University in 2014. Together with his multidisciplinary team at Aga Khan University, he has developed a pediatric genetics clinic, hereditary cancer clinic, adult neurogenetics clinic, and perinatal genetic clinics, the first of their kind in Pakistan. You should be very proud of him, I have to say. He is on the board of a member of parent support group for rare genetic disorders, including the Karachi Down Syndrome Program, the DEBRA, DEBRA Pakistan. He continually strives to make the advances in genetics and genomics accessible to people in Pakistan and create a team of healthcare professionals who may deliver precision medicine solution to population with the highest burden of genetic disorder. So we look forward to listen to your talk, Dr. Kirmani, which titled Dealing with Consanguinity in Pakistani Society, a reality that wouldn't go away. So the floor is yours. Go ahead.
Great. Thank you so much, Dr. Abu-Rmeileh, and thank you for that very, very kind introduction. I'd also like to thank the CBEC team for inviting me to give this talk. And this talk is a result of many discussions that I've had with Dr. Amir Jafri and with other colleagues, Dr. Natasha. And I think it's a subject that is somewhat shrouded in taboo in our society, and it's very important to be openly able to talk about it. So I'm very glad to get the opportunity. And perhaps as I was, going to do this talk, this may be a better title for the talk, because to discuss a controversial topic objectively, one must look at the good, the bad, and the ugly. And I think that's really what consanguinity sometimes brings out in some of us. And I think we must learn to manage our emotions as we deal with this subject, because if you're a care provider, or if you're talking to families who come from a consanguineous background, one has to be very, very careful, because you don't want to look down upon people who are from consanguineous unions. You want to be able to counsel them appropriately. I have no financial disclosures, no conflicts of interest. And my point is not to stir up controversy, but to actually have a vibrant discussion and then be able to make this topic less controversial. So I think that's kind of hopefully going to be something. And I'm going to begin with an audience poll, because I think it's important, if we're really going to have an honest conversation, to look inwards first. So my first question to the audience, and people can give an answer on the chat. People who are here in the room can raise their hands. How many people feel that cousin marriages should be made against the law in Pakistan? Because we keep hearing it that this is public enemy number one, and that we must make a concerted effort to fight this phenomenon. So are there any people in the audience, either online or in the room, who actually feel that we need legislation against this? Okay, so we have one participant in the room who thinks that we need legislation. Okay, so it certainly does stir up some strong feelings, but and that's just, again, one perspective. There may be many others to acknowledge. But then let's get a bit personal, and I've never done this before. I've always wanted to do it, so I thought this would be a good opportunity. I want to ask people in the audience, how many of you are either products of a consanguineous union, are themselves in a consanguineous union, or have children or siblings who are in a consanguineous union? And I don't mean to embarrass people, or I don't mean to make people feel pointed out at, but I think that's the important thing. You cannot have a discussion objectively until you really have a chance to have some personal reflection about it and have a talk with someone who is in those shoes. So, the point here is this: There are people who may be made to feel ashamed or guilty because they come from a consanguineous union, or because they, quote unquote, allowed a consanguineous union under their watch. Is there anyone who's sort of made to feel bad, or maybe inwardly felt that, oh, I'm an educated person, I shouldn't be, you know, in this kind of relationship or something? No, so there's no shame. So I ask this because as a clinical geneticist, I've had people feel or been made to feel very bad, that almost to the point where they're made to feel bad that it's their fault that they chose to be in a consanguineous union, that they have children who are suffering. So the children are suffering because of their mistakes or their parents' mistakes. So again, this wasn't meant to stir up controversy, but really to have some inward reflection. This is a bit of a busy slide, but I'm going to walk you through it because it sort of, gives us some important definitions which we will use. The word consanguineous actually comes from co-sanguine. Sanguine is blood. Co-sanguine means from the same blood, right? So basically, if you are the product of a union between second cousins or closer relatives, it could be first cousins, it could be first cousins once removed, it could be even an uncle niece or an aunt nephew a relationship that does happen in certain cultures, that would be defined as being consanguinity. There is a concept of a term called the coefficient of inbreeding, and that's basically the probability of inheriting two copies of the same allele from an ancestor that occurs on both sides of the pedigree. So this is in context of recessive disorders. And here are this is the term that is used, is called identical by descent. So on both copies of the gene, you have an identical allele because your parents were related to each other. So it came from, both sides of the family, but up above, both sides of the family are connected rather than being from two different family trees. And if you look, the F of 1 in 16th or 0.0625 is the coefficient of inbreeding for first cousin unions, meaning 1 in 16 alleles, right? And you have basically, 3 billion base pairs, right? So 1 in 16 of them is identical by descent. If you're a biologist and a geneticist, you want more diversity in your genome, right? In general, although there could be a case made for thorough breeding, as they call it, but in general, the more diversity, your backpack is filled with more tools to try to fight off or ward off disease. And if you have more alleles identical by descent, if one of them is if they're defective, then you have less tools to fight off certain things and maybe at risk for certain others. It goes down when you're second cousin unions, but it's still 1 in 64. And you can see it's actually even closer for double first cousins. The term double first cousin means you yourself are first cousins and your parents were also first cousins. So, that inbreeding is sort of doubled. And you can see that 1 in 8 alleles are then, identical by descent. They did a study all over Pakistan because you've got some averages of how common cousin marriages are. And for the average Pakistani union, the F is somewhere between first and second cousin marriages. So it kind of gives you a sense at a population level what one is looking at. This is just no one is judging good or bad, but those are the numbers. Right? Here's what the international map of consanguinity looks like. And I'm not sure if it's very clear, but Pakistan, which is sort of the dark blue longitudinal spot, is the most darkest part on the map. It is the most highly consanguineous country currently in the world. If you look more so than even Saudi Arabia, Jordan, Kuwait, Sudan, Iraq, UAE, and Turkey. So 70% is kind of the average. The numbers range anywhere from 50 to 80%. Obviously, there is a rural skew to that. And since most of our population is rural, that skew is clearly there. But even in cities, we tend to be very tribal. We tend to be very community-based. And sometimes communities may not actually answer the question that they are married and cousins, because they're not, but because they have similar ancestors, that community inbreeding may contribute to the risk of diseases. And you can see data clearly shows that autosomal recessive disorders occur at about 18 times higher rate in cousin marriages. And just in general, the prevalence of birth defects or malformations tend to be much, much more in our population compared to, say, an outbred population like the Europeans. So here's why I'm going to go with the good, the bad, the ugly, but one must acknowledge that society perceives there to be some good with consanguinity, and you cannot have an objective discussion without touching on this, right? So, and some of these studies that I've referenced do have flaws, and people have reviewed these, and yes, no data coming from this is perfect, but I'm just going to put it out there, acknowledging that there are imperfections in this data, but they do say that consanguinity leads to more stable marital relationships and a lower divorce rate. There seem to be less financial hardships because maybe there's less dowry expectations within the family compared to outside. Certainly the advantage or perceived advantage of preservation of land holdings, etc. There is an argument to be made of improved female autonomy because she's in more familiar surroundings, maybe around familiar people, as opposed to people with completely different customs, although you could argue otherwise too. There is an argument for better compatibility with in-laws. Some data suggests, based on surveys, less domestic violence, although I'm sure there are exceptions to that. Less hidden uncertainties is what people say when you ask them why they would prefer this. And then this concept of continuity of cultural practices. If people really value the culture that they practice, they want it to be able to go down the generations and not get diluted over time. And then, you know, interestingly, and I was surprised to learn this, but even as a biologist, there is some evidence to suggest that there may be some good biologically with consanguinity. So if you're an animal breeder, you will want to preserve certain traits and you will try to breed those true so that those get preserved in generations. So if you open that up to certain, you know, preferable traits in society, maybe that's an argument that can be made. There is increased gross fertility, although it is probably you know, balanced out by the fact that there's more malformations and a higher neonatal fatality rate with consanguineous unions. So probably the net fertility rate is balanced, but there is some evidence to suggest that. Interestingly, some chronic diseases like breast cancer and multiple sclerosis, again, maybe flawed studies, but that's in the literature. I've referenced that. Lesser incidence in consanguineous populations. And some people think, and this is very, very interesting, that maybe this is nature's way of eliminating bad alleles by causing lethal disorders so that then that person cannot reproduce and it doesn't go on, versus if you marry outside the family, that carrier state will go on to be perpetuated for generations to come. Again, it's sort of a mixed biological argument because the incidence of these diseases is much more in consanguineous unions, but clearly there are people, you know, looking at this from both sides of the street, which is very good to do. Here's the bad, which I think most medical providers tend to recognize. There is definitely an increased incidence of birth defects and autosomal recessive disorders, acknowledging the fact that some birth defects like cleft lip and palate, spina bifida, etc., are not monogenic. They're not inherited in a recessive fashion, yet they tend to occur more in consanguineous unions. So probably multiple factors come together and increase that risk. Interestingly, the diseases that plague most of the population in adult life also seem to happen at a higher rate. Ischemic heart disease, hypertension, type 2 diabetes, schizophrenia, etc. So probably there are at-risk alleles, and they may be getting enriched in certain families and coming down that way. There is clearly a link between increased perinatal, neonatal, childhood, and adult morbidity and mortality. And that's across the spectrum. But here's some data that's coming up very recently, right? So For those who work in the sort of maternal child health space, they know that even though there have been advances made in child mortality reduction over the last 20 or 30 years, neonatal mortality continues to be Pakistan's Achilles heel. In fact, we are still the most dangerous nation on day one of life for the human being. The most dangerous. There are probably 35 to 40 more countries that have a worse GDP, worse economic conditions than us. Yet our neonatal mortality on day one is worse than theirs. Could it be that it's our consanguinity and all of the other genetic factors that are inherited in that way? It hasn't been proven, but it's an interesting hypothesis to do. At a population level, there is some evidence, although this is controversial, that low IQ and intellectual disability may be more prevalent in consanguineous populations. And clearly, when you're dealing with all of this burden of disease, and if you're thinking that it's all related to consanguinity, then it does lead to a higher burden on society on both the emotional as well as the financial front. And for the sake of discussion, I've kind of put these on both sides. So the way people react to consanguinity can sometimes be very ugly. And sometimes the actual consequences of consanguinity can do the same. So people may argue that it is an expectation for a young person growing up in our society to marry within the family. And that is an unreasonable expectation because it takes away from the autonomy of that individual to choose their life partner. And certainly the tribal and caste systems tend to limit those choices. It is quite clear that if you were to mandate premarital screening, you are actually putting female carriers at risk for being stigmatized and maybe becoming totally unmarriageable, because nothing remains private in our societies and men get away with most things. And so the good intentioned people, so most people don't know this, but Sindh, Punjab, and KPK currently have laws on paper that you're supposed to be tested for beta thalassemia prior to having the marriage certificate given to you. Obviously, enforcement doesn't happen, so it doesn't happen, but the laws are there. But again, first of all, what's the point of a law if you can't enforce it? Number two, it does put a lot of these women at risk, especially. So that's something to be acknowledged. Clearly, there are clear examples in our experience of people fearing the medical community because they're going to be judged for being in a consanguineous unit. They may not actually seek medical care or may not seek advice because they fear retribution, or at least they're going to be felt really bad about it. And that this whole guilt of they are responsible for their child's suffering. Also, improper genetic counseling, again, people being told to not have children or to go ahead and have children because it's Allah's will. It's, both sides of the story could be argued. And then again, who do they marry? Their choice of their partner. All of those things, in my mind, limit the autonomy that an individual deserves in society. So here's a case scenario that we face quite regularly in our clinic, where a family comes in. They have multiple children who have either died or are currently suffering from an autosomal recessive disorder. They do have some healthy children too, and yet they desire more children. And the question is, how would you counsel them, right? And it's an important question because one response may be, you already have 3 healthy children. Why do you want more, right? Just stop. It might be, oh, you definitely do deserve a boy, so let's try to have you have a boy, right? That has its, sort of unethical connotations as well. Or do you try to assist them because that's what their wishes are? So it's really important, and how you break the story to them will determine their actions, because they've come to you and you are the professional being sort of, being asked to help them. And when you try to counsel them about why this happened, what's the reason, here's some common responses that do come, right? First of all, there's a bit of denial because they say, there are multiple cousin marriages in our family for generations. No one's seen this before. Why are you insisting this is genetic? right? Whether when it's clear that it's genetic, right? And then we do hear this quite a bit, that if cousin marriages were so bad, Islam would have prohibited them. And so because they are not prohibited in Islam, they are okay. And then I've also heard that, Prophet Muhammad married his first cousin. So if no one's come up to me and say it's sunnah to marry your first cousin, but it's really still a justification that's there. And then sort of this general, we are aware health and disease are both Allah's will. So whatever you tell us or don't tell us, if it's going to happen, it's going to happen. So we may as well take our chances. So I don't have good answers for what's the best counseling formula, because it has to be individualized to the family's needs. But I think it's important to listen to their needs and then respond in your counseling efforts. When you see news headlines like this, most people would not kind of think this is wrong in any way, because that's the message we need to get out, right? But, this is, at some level, you are sort of demonizing an issue. If you notice, I haven't called consanguinity a problem. I'm calling it an issue. And I think it's important, at least that's my personal view, because once you approach it as a problem, you've already defined your enemy. And I think it has to be something, it has to be a conversation with society, because society seems to be quite entrenched in this phenomenon. And here's the dilemma that I want to bring up to the esteemed audience here, right? There could be an individual family approach where autonomy is the major driver of your discussion. And if they so wish to proceed with the risk of having a child with an autosomal recessive disorder, they acknowledge that the risk is 25%, yet they feel that 75% is a fantastic chance to have a healthy child, and they're willing to leave it up to God. So be it. Who are you to stop them? You could kind of certainly have that, and certainly you're not going to outlaw them to have children, right? But there's a public health approach where you have a responsibility to society. You have a responsibility to that unborn child who's going to suffer their whole life, even if it's a short life, for what to do. And do you try in your power or position to prevent that occurrence, because after you, they may not come to any medical professional or any other professional with the knowledge. And here's where I really struggle. The seatbelt law example. Who in the audience can argue that outlawing, or making it a law to buckle up is a bad thing? It's encroaching on someone's freedom to make them buckle up, right? When you buckle up, the only life you're saving is your own, right? It's not someone else's. It's truly your own. You're responsible, right? So the autonomy arguers could clearly say, hey, it's my life. I don't like this strap. I ain't going to do it. But you are going to be ticketed. You're going to not be allowed to drive the car if, you don't buckle up. Should you deal with consanguinity in the same way? These people are taking a risk that is above and beyond the standard biological risk of having a child outside their family. Should you somehow try to prevent them from doing it because you know more than them about the consequences, and you've seen it play out in a different way? They may have never seen a child with thalassemia, so they don't have that perspective, right? So I struggle with this, and I do not have an answer. But I want people to kind of think about this, because it's really important, because it's very easy for like-minded people in a closed room to make a very strong argument and see it all the way through into law, and not even involve the real stakeholders in the conversation, which is the population. And that's why this term of even dealing with consanguinity has some interesting connotations, right? And here's my sort of practical framework, right? First of all, I think we need to destigmatize it, right? Acknowledge that it is a cultural practice that is preferred, and that there are some perceived goods in it. Once you acknowledge that, you normalize it, and then you try to figure out, how do we help the people? How do we help the population at large, right? And there's really no way to deal with it without educating people about it first. Because, having the top-down approach really does not work. And I believe that involving the religious leaders and the medical community are the keys to success. You begin with them. Once you get them on board and they understand the issues, they will be your strongest advocates in moving forward and really then transmitting that education to the rest of the population. And I think that's going to be very applicable to our setting. And at the same time, you need to have affordable population level carrier screening. So affordable genetic testing for the most common diseases in your population. You need to do epidemiological studies in the population to define what's common and then design testing. And the good news about genetic sequencing is that the way the prices are coming down, this will be a reality. We can actually make it work. And there are some very interesting examples. I'll just share two small examples. So the Ashkenazi Jewish community in New York City was essentially able to eliminate the incidence of Tay-Sachs disease in their population. A local group of geneticists in New York went to the synagogues. The good thing about the Ashkenazi Jewish community is that all their marriages have to be sanctioned by the rabbi. So the union, even if a couple meet spontaneously, when they want to get married, they need the blessings of the rabbi. So first, it was an education campaign around the synagogues, around the rabbis. Once the rabbis got it, that it was in their hands, they started advocating for carrier screening for young people of age 18 years and older who were potential to get married and have children later on. And then they kept a registry of that. So when a couple came, they could go back in the register and see whether both of them were carriers or not. And if they were, simply they were just informed of the risk. They were not told to not be in a union. They were just informed, and they were informed of their choices. They could get prenatal diagnosis, and now they could get pre-implantation genetic diagnosis. So a lot of them chose not to go through with the union, but some of them did and proceeded to have healthy children. So the end goal was not to do away with consanguinity, because if you're an Ashkenazi Jew in New York, you only have limited choices. But the end goal was to eliminate the disease, which they absolutely did. So I think if you have the end goal in mind, you will be successful. The other examples are Iran and Turkey, and they're kind of a bit tricky because both are authoritarian regimes where enforcement is relatively easy compared to other countries where things are more challenging. But for beta thalassemia, both those countries took on, thalassemia as a major public health problem. And they did, before they even embarked on testing, they did a 2-year nationwide public education campaign through the mosques, through the schools. They added, thalassemia education into the curriculum, etc., and so forth. And once they did that, that's when they added their carrier screening. That's when they mandated it, and that's when they enforced it. So again, starting with the education was a great example of success. So I'm going to conclude, and I'm hoping that we can actually have a good discussion around this, is that, consanguinity is a complex issue, and it must be dealt with rationally and dispassionately. I think our problem with dealing with it so far is that we've been too passionate on both sides of the spectrum, and we need to be dispassionate about it to move forward. The pros and cons need to be acknowledged by both sides, and I believe that the individual as well as the public health approach are acceptable depending on what situation you're in. They should not be treated as being mutually exclusive. One must begin by respecting the values of the community that you are doing this for. If you act as the know-it-all and go in and try to talk down on them, you've already lost the battle. And I think, that principle of, at first do no harm is very, very clearly applicable to our discussions about consanguinity, because I highlighted some of the harms that we can do in our efforts to try to do good. So with that, I'd like to acknowledge Fiza, who's my partner in crime in genetic counseling at AKU, and Dr. Amir Jafri and Natasha Anwar, who really sort of have been able to bring this discussion together And I'm hoping that this is just the beginning, because we need to carry this forward outside of these walls, outside of this group. And it would be wonderful to hear international perspectives on this, personal perspectives on this. So happy to take questions and move forward with the discussion. Thank you.
Thank you very much, Dr. Kirmani. Very interesting discussion, a presentation, and I will take the pleasure, the advantage of being the chair to ask my questions first, and then I will go into the chat box. But first, I'm a product of a relative marriage. So my parents are cousins.
Dr. Niveen, I think your microphone is not working.
Oh.
It is, the voice is very low.
Now, is it okay?
Yes, it is better.
Okay, thank you. So just to repeat that it's a very interesting talk. And I have to declare that I am a product of a relative marriage. So my parents are cousins. But we take it as a good aspect, because we believe that we are transferring the intelligence and high IQ. So this is contradictory to what you have said. But I would like to share with you the experience of thalassemia in Palestine, which goes exactly with your suggestion about engaging religious people, regulation, and awareness among the community. So we reached 0 newborn cases of thalassemia in 2013. Now we are witnessing new cases, which is like 1 or 2 every year. And these are very special cases from previous marriages or people getting married outside the country. So we had a very successful, and we can have this discussion. But just going back to this note, let's go to the chat box, and we have a comment from Lena asking about how we can empower the public and educating them, providing them with accurate information. So I will give you the comment and you can reflect, Dr. Kirmani.
Great. Thank you so much for that, sharing your experience about thalassemia in Palestine. I think that's wonderful, and we probably have a lot to learn from you. So I think we certainly will reach out to you and ask you about how you did it. The question regarding how to do a public education campaign, I think you need to first get all the stakeholders together. I think you need to really ask, what is your baseline education level? What is the awareness level? What are the cultural practices? Because, in larger, more diverse countries, there may be different religious sects, there may be different cultures, they may have different preferences and views. So I think trying to learn about that, and then I think it's a multisectorial approach. You will have to involve people who are involved in public education, people who do these kind of campaigns. I remember growing up, there was a family planning campaign that was done nationwide, and it used to be on the radio and TV, etc. It was very, thoughtfully done, and it became part of everyday fabric of discussion that 2 kids is what is preferred. Whether it was effective or not is a different question. But something like that will have to be done so that it's at least out there. It's a discussion, but it has to be done in a sensitive manner. So I don't have a good answer, because I come from a very, very clinical background. So I would need help from people who are in CBEC and people who are in public education, because they're the ones who actually have the tools and who will have the pulse on the ground to actually know what the community wants. I'm happy to have other colleagues. Maybe Dr. Mozam, you want to comment on this?
Yeah, so there's just one comment that we can take. So I think it is a duty as scientists, researchers, public health specialists to empower the public with the accurate information and give them access to tools that can help make the right choice. But if it is a contagious issue that places the entire population at risk, then we can give the scientific community more liberty to dictate and mandate health recommendations. I would love to hear your opinion.
Yeah, I think that's very nicely put, in the sense that if you're dealing with COVID, right, then you're dealing with an infectious issue where if someone is not responsible with their masking or hand washing or vaccination, then not only are they at risk, but many other people unrelated to them are at risk. Consanguinity is a bit different because it's certainly the risk is to your children or to people who are within your immediate circle of influence. So I think the two issues in terms of legislation, in terms of enforcement, need to be dealt with differently. That's my view. Yes, Dr. Mosen.
Can I make a comment? Okay, this is. Yeah. Okay. Thank you, Dr. Salman. I really enjoyed your talk. These are the things we should be talking about more often than just science. There are a couple of interesting things. The issue of autonomy versus public health. I think that argument for consanguineous marriages perhaps doesn't work. So, for example, United States, they are always beating the drums for autonomy. And yet in the United States, first cousin marriages are not.
24 out of 50 states.
They're put under, incest. My question to you was, do you feel when you kind of took a more or less a show of hands, there's several people sitting around this table who are products of consanguineous marriages. Do you see any irony in this group sitting over here and talking about the downside of consanguineous marriages? And those around the table who are healthcare professionals, it's kind of ironical, would you say, that we would then go out and say, look, it's not a good idea, don't get married with your first cousin? What do you think? Is there an elitist aspect to this whole discussion? Because there's nobody from the rural representatives here.
Well, so here's the people who are products of a consanguineous union had nothing to do with it, right? So they had no choice in the matter, right?
Yeah, but there are also people sitting here who are married to first cousins.
Yeah. So I think, again, life is a learning process, and you learn and you evolve. I'm not saying that they should have made a different decision if they had learned what they know today about the dangers, but at least they should be well informed of their risks. And it's like driving a car without wearing a seatbelt. All of us have done it. And because all of us are here, none of us suffered a life-threatening accident because of it. But we all know the importance of doing it, right? So I think you have to approach being in a consanguineous union the same way. It is riskier, but it's not an absolute, indication that something bad will happen.
So that's how you would approach it to your patients?
Yes, because the vast majority of consanguineous unions will actually lead to healthy outcomes. Yes.
Can I add something?
Okay. We have a participant.
I was just saying that I am also a cousin married couple. When I told my parents that it's a bad and it may cause diseases to our children, they didn't follow my talk or suggestion. After that time, after a few years, one of my cousins was getting married, and I suggested him not to marry that cousin. So they didn't even follow. Now, currently, we have two autosomal recessive disorder patients in our family, and almost three skin disease disorder couples in our society. Now I think they are thinking about the outcomes of cousin marriages. So this is really a very, very hard thing to make them understand. Even I cannot manage to convince them about my brother's marriage. But as you also mentioned that people are always say that you have not get anything, your children are good, why shouldn't we marry? So that's the real problem, to convince the
thank you so much for sharing that perspective, because we cannot educate the community without knowing that that's where they are coming from. Yes. Right? And so doing an education campaign around what the possible risks are, what the hidden risks are. So studies that have been done in Pakistan show that all of us are carrying at least 3 to 4 recessive alleles, right? So even in a random union that could happen, but it's much, much more likely to happen in a consanguineous union. So it's really a matter, and it's very hard, because if you haven't suffered a bad outcome, it's very hard to perceive risk, right? It's kind of the adolescent mind, right? Because they feel that they're sort of invincible. But I think giving them that perspective, so if they have never seen thalassemia, showing them the suffering that thalassemia can cause, maybe something that could help. But it has to be, and once it's in here is when it'll actually be enforced.
Dr. Niveen, may I ask a question?
Yes, yes.
So, Dr. Salman, you make it sound as if marriages are a choice.
Yes,
Yes.
absolutely.
So in most cases, in many cases in our society, actually they're not. They're just a given that this is happening. You're marrying this person because that person is available. It's in the baradri, it's in the tribe, it's in the community. And therefore you also our daughters remains in the same community or the same khandan or the family. Also our resources, the inheritance will remain. So there are many. So that is one thing. The other thing, of course, is now that you were talking about, given our burden of thalassemia, for instance, it is mind-boggling why people have not understood that there is some connection between bad outcomes and cousin marriages, which is a decision that they should also be making themselves, or their parents should be making for them. So the disconnect, first of all, there's within our society, the choice sometimes does not actually weigh in on.
It's not autonomous as it's supposed to be.
So it's not as autonomous. Plus, the other thing is, people do not seem to have made the connection between cousin marriages and, for instance, thalassemia, like Palestine has done or Iran has done. We have not been able to do that, even though they're also resource constrained communities and countries.
But if their religious leaders were involved,
yes,
so maybe that's
so one way. So the Jewish community you mentioned, because it's a well-knit small community with a very strong religious leadership. On one hand, we talk about religion being very, very strong over here and religious leaders being very strong over here, but their energy is spent in something completely different.
Right.
So this was to be channelized in such a fashion, maybe your struggle would be a little less.
Absolutely agree. Thank you for those comments.
And if I may, just before closing, if I may add how we can link the discussion today, if marriage is not a choice and people are getting married to their relatives, to the discussion we had yesterday about gene editing. So would this be more attractive, so people will get married and then we will prevent the consequence by gene editing? It's just, I know this will create a whole discussion, but I'm just raising this issue before you give your last words and comments. Thank you.
Right. And I'm glad you bring that up, because as treatments do come up, that could be an argument, right? In fact, I have faced that with SMA, which is spinal muscular atrophy. Now there's a gene therapy for it. It's the most expensive drug in the world, $2.1 million. There have been couples who have been counseled and who've been given the choice to terminate the fetus because the fetus was positive, and they said, we're going to take our chances with gene therapy. And they've gone on to have a child, and believe it or not, that child actually got the gene therapy. What are the chances? But it did happen. So it does happen, but I think it is, from a public health perspective, that is absolutely wrong, right? Because that, I think, is resources very poorly spent and a preventable disease. So it's like saying to the child, you can start smoking from day one, and we'll just do a lung transplant for you when you get cancer. So I wouldn't like to argue that one.
Well, thank you very much for this interesting discussion. It's very, very interesting. And if anyone has any question, we will keep it for you until the end, and when we have the panel discussion at the last session. So let's move forward. Thank you very much, Dr. Salman.
Thank you.
And we'll move forward and listen to Fiza Akbar, if I'm pronouncing the name correctly. Fiza Akbar is a senior instructor at the Division of Women and Child Health at the Aga Khan University, Karachi. She holds an undergraduate degree in biotechnology and psychology from Foreman Christian College, Lahore, followed by a master from University of Manchester in genomic medicine. And she's going to present to us advances in genomics, challenges of genetics counseling in Pakistan. So
hello,
Dr.
sorry.
Fiza, the floor is yours.
Sorry, can I just quickly make a correction?
Yeah,
I think it's Emmanuel Turling who's supposed to be giving a presentation.
Yeah, I'm looking at the old program.
Yeah.
You know, the distance thing, so it's apologies. So
No.
okay, so Emmanuel Turling is the technical officer within the Unit of Emerging Technologies, Research Prioritization and Support in the Science Division at the World Health Organization. She's currently working on activities associated with the governance of dual-use research and the responsible direct of life science. She has experience in the governance of science and technology, having worked for the WHO from 2004 until 2011, including the project Responsible Life Science Research for Global Health Security. Before joining the WHO, she was based at the Harvard Sussex Program, University of Sussex, United Kingdom. She holds a Master of Science and a doctorate in Science and Technology Policy from the University of Sussex, United Kingdom. Sorry, Emmanuel, the floor is yours. Sorry.
Thank you very much. Do you hear me well? Okay, thank you. So good morning, good afternoon, and good evening. So I'm Emmanuel Turling, and I am working in the Science Division of WHO as a technical officer. Okay, let me see, perhaps if you could share my slide, otherwise I can try it from here as well. Just let me know what's the easiest.
Yeah, we're just opening up your slides. Just give
Okay.
us a minute. Thank you.
Thank you. Oh, thank you. Great.
Yeah? Okay, we're just going to go to full screen.
That works well. Thank you. So today I'm here, in fact, in my previous role also, I worked for the Human Genome Editing project, and I was supporting WHO Secretariat in their work of with the WHO advisory on human genome editing. So I'm here today in that previous role as a consultant helping the WHO Secretariat in that task with the Advisory Committee on Human Genome Editing. And perhaps as a background also, I'd like just to say a few words where this word was and is located. So it's within the Science Division. And the Science Division was created as part of WHO transformation in 2019. And the main goal and vision also of the Science Division is really to harness the power of science and technology to improve our health, to improve our societies, and to improve our environment. And so, of course, there is a recognition that with new technologies and with existing technologies, there are many opportunities for improving our health, but there are also related risks. And so one of the aim also with the creation of the Science Division was to be in a position to actually have governance systems in a proactive way and not only reacting to new or emerging technologies. So that was just a quick word about the context where human genome editing work has been carried out. So the objective of this presentation today will be to provide you with a brief overview of the work of the WHO Advisory Committee on Human Genome Editing and two reports that were published last year on the governance of human genome editing. I will mainly focus on the governance framework, and I will just also present briefly two of the recommendations of the recommendation report. So thank you. Thank you for moving the slide. So this is fine. So in December 2018, the World Health Organization established a global multidisciplinary expert advisory committee to examine the scientific, ethical, social, and legal challenges associated with human genome editing, and that is somatic, non-heritable germline, and heritable germline. The committee members were drawn from each of the WHO region, Africa, the America, Southeast Asia, Europe, Eastern Mediterranean, and Western Pacific. The committee worked on a consultative manner and built on existing initiatives. And so it works with the several UN agencies, different regional, national health ministries, regulatory authorities, national research institutes, national boards of technology, patient groups, patient advocates, civil society organization, indigenous groups, private company, campaign groups, industry association, national academies, bioethics committees, university, medical school, academic research institutions. So it was really a broad engagement process, a broad consultative also approach, and participants actually were consulted from 29 distinct groups, and these really contributed to the work and the meetings of the committee. The committee also held 2 in-person and 15 online topic-specific meetings, drawing on contribution from 71 distinct groups. Next slide, please. The committee, thank you. The committee was asked to advise and make recommendation on appropriate institutional, national, regional, and global governance mechanisms for human genome editing. So that was its scope of work, its remit. Its remit, however, did not include non-human application of genome editing. And importantly, the remit of the committee did not include a review of the safety and efficacy matters of human genome editing. This was done by the International Commission on the Clinical Use of Human Germline Genome Editing that was convened by the US National Academy of Science, the US National Academy of Medicines, and the UK Rare Societies, with the participation of academies of science and medicines from around the world. So the report of the WHO committee builds on their report, but it focused on the governance of the technology application, including not only heritable germline genome editing, but also non-heritable forms of editing as well. The charge from the Director General covered 3 topics in human genome editing. So that is a somatic, non-heritable germline, and heritable germline. So somatic, that's typical blood cells that are not part of the germline. Germline, that is egg, sperm, their precursor or early embryos, so in the lab, but not for reproduction. And heritable, the genetic alteration that might be passed on to future generations, so that germline for reproduction. The mandate included scientific and ethical and societal issues, and somatic, germline, and heritable have different time horizon. So that was also recognized by the committee. And the committee was also tasked to situate its finding within the broader emerging technology landscape. This is also a very important point that also was evident in the recommendation and governance framework of the committee. So on this slide shows that the several products done by the committee, and the committee worked for almost 2 years. And so it developed these 5 main products: a global clinical trial registry on human genome editing, a policy statement by the Director General that it would be irresponsible to use genetically altered embryos for reproduction, a governance framework for human genome editing, so that's the main topic of discussion today, 9 recommendations for governance and oversight, and the reports of the committee's work. All these documents, all these different inputs are available on WHO's website if you wish to have more, a deeper dive in any of these different outputs. Next slide, please. Thank you. The committee understood that it needed to produce a framework, a governance framework, that would offer guidance in how to develop policy and tools to implement policy choice. So much of the final product was informed by the meetings of the committee and the two also online consultations that were done during the work of the committee. Another point was that the framework needed to be scalable, it needed to be sustainable and fit for purpose at different levels of governance, whether it's the local, national, regional, or international level, and also that it should work in different settings where regulation may be weaker or where genome editing is not being pursued also at present. But above all, it was deemed that the governance framework should be practical and also usable. Next slide, please. This is a quick overview of the main contents of the governance framework with an introduction with the importance of situating their work within the work of good governance of new and emerging technologies. The governance of human genome editing, including values and principles and associated commitment to guide decision-making. And then in part 4, there is a list of tools, institution, processes for governance of human genome editing. Part 5, I list 7 scenarios where human genome editing will arise and how the framework could be used. And then the last part is about key consideration on implementation, metrics, and review. Next slide, please. Thank you. This slide and the next, in fact, shows that a rule differs around the world, but that there are also pre-existing regulation on germline and heritable human genome editing. So on this slide, which shows policies on human germline genome editing, so not for reproduction. And you can see, for instance, in red color, that's where policies are prohibiting human germline genome editing. In yellow, where there is prohibition, but with exception. In green, where it's permitted. And then other color shows whether it's indeterminate, where there is no relevant information available, or whether it was not included in the survey. This is a study or a survey that was done by Françoise Bélis and colleagues on human germline and heritable genome editing that was published in the CRISPR journal. On the next slide, that shows policies on heritable human genome editing, so for reproduction. And there you see again the different colors according to the status of the law and whether it's prohibited with exception, permitted, indeterminate, and again whether there's no relevant information or not included in the survey. Next slide, please. That the framework also recognized that policies governing the technology will likely differ from country to country. Nonetheless, the framework calls on all countries to incorporate key values and principles into their chosen policies. And these include, for instance, inclusiveness, equal moral worth, social justice, responsible stewardship of science, solidarity, global health justice, and to use these values and principles to inform both how and what policy decisions are made. And these values and principles are a critical part of the committee's work, and they're really embedded throughout the governance framework and throughout its recommendation. And this is important because they didn't want it to have just a few ethical values and principles somewhere at the beginning of a document and then not referring to it towards the end of the document. So even some of the scenarios, the list of questions are also referring to these ethical values and principles. The committee also looked at special challenges around human genome editing. And they identify 5 special challenges, which include postnatal somatic human genome editing, prenatal in utero somatic human genome editing, heritable human genome editing, human epigenetic editing, and enhancement. And so in the document, you will see for these special challenges, for instance, they're also associated with a list of questions for the decision makers to help in the governance of these specific challenges. Next slide, please. The framework also outlines the range of tools, of policy tools and mechanisms and institutions and processes that might be used for governance. And they include not only domestic regulation, but they also include international instruments, institutional standards, funding conditions, professional guidelines, and patent licensing prevention, for instance, among others. So that's really the understanding also of how governance is being put in this context and understood in the framework. So it really emphasized the need to develop these tools also with the input from a broad and inclusive range of interested parties. Next slide, please. The report then applies those different elements, so the values and principles, some of the possible tools to a set of different scenarios in which human genome editing is offered in a research or in clinical settings. And these are examples of how the framework might be used in practice and also as policies are developed around the world. So these set of scenarios are hypothetical stories, but yet realistic, and they're there to help decision makers and those in charge of governing human genome editing to see how the framework could be used, and also to illustrate the different types of challenges that might be encountered in human genome editing and the governance. Next slide, please. So the scenario were developed around 3 areas. The first one was somatic human genome editing with 4 types of scenario on clinical trials, for instance, for sickle cell disease, clinical trials for Huntington disease, unscrupulous entrepreneurs in clinics, and enhanced athletic ability. There's also one scenario on heritable human genome editing, and another one on prenatal in utero somatic human genome editing. Next slide, please. So just to give you a snapshot on how those scenarios are made, in fact, you have first, and here is the quick snapshot on the scenario 1 on somatic human genome editing, clinical trials for sickle cell disease. So the scenario starts with a short story, with a short paragraph that explain an hypothetical situation. And then these scenarios breaks down different issues. And for instance, in the scenarios on clinical trials for sickle cell disease, the scenario highlight issues about good practices in international research collaboration and clinical trials. It also put forward issues regarding regulatory capacity, different competing approaches to providing a public health response, also issues around patient access and standard of care. And then there is a list of questions that should be considered when developing oversight measures. And of course, there's other questions that may also arise. And then the scenario ends with different governance tool, institution, and processes that are put forward in this case study. Scenario. So this, in this, I'll end some of the key remarks on the governance framework. And I'd like now to give you also a brief overview on the recommendation report. So that's the other document that was published by the Advisory Committee on Human Genome Editing. And so as the committee worked, in fact, progress over the 2 years, and also through their extensive engagement during this work, the committee was also alerted of the real opportunities but also challenges that went beyond the governance framework. So this is where the recommendation document comes in and is in fact supplementary to the governance framework. And the committee produced a series of recommendations in 9 discrete areas. And these are leadership by WHO and its Director General, international collaboration for effective governance and oversight, human genome editing registries, international research and medical travel, illegal, unregistered, unethical, or unsafe research and other activities. Also recommendation on intellectual property, education, engagement, and empowerment, ethical values and principles for use by WHO. And the last one is the review of their recommendation. So the committee recognized that this work is in fact the beginning of a process, and that so they put forward this aspect of living recommendation. So implementation is key. And with this in mind, the committee was advising that a review needed to take place in no more than 3 years to review these different parts of their work. Next slide, please. So today I will just provide a brief overview on 2 of these recommendations. One was to develop human genome editing registries. And so the idea behind this is that good policy begins with good facts. And so the registry can help to provide essential information about the state of science and the direction of future application. And so the recommendation to pilot a human genome editing registry dates back, in fact, from the first recommendation that was made by the committee. And so it was recognized at the time that this was also the start of a process and not the end of one. And so now the current human genome editing clinical trial registry needs to be further developed. It is on WHO's website if you want to have a look also at the pilot of this clinical registry on human genome editing. And it needs to be further developed, not only in terms of the scope of the work it captures, but also the tools that are used to run it. So given this, that the committee has made a series of further recommendations as to how the clinical trial registry can be improved. And this include the establishment, for instance, of a vetting mechanism to flag clinical trials that may be of concern, and also the development of an additional registry on basic and preclinical research registry, which should be done in collaboration with the research community in order to capture relevant preclinical work that will help policymakers to govern proactively rather than reactively to major development in the field. So that was a quick overview on the human genome editing registries. Next slide, please. Thank you. And this is another recommendation on education, engagement, and empowerment. A major focus of the committee's work was on what is called education, engagement, and empowerment, to cover really the full spectrum of what the committee believed necessary that now currently, but also for going forward. And this is an area where the committee was also greatly influenced by its own engagement activity that have been done throughout the 2 years of work, and also by what has by the outstanding also engagement initiative that have and are taking place on human genome editing. But that said, the committee concluded that there was a real need for inclusive global dialogue. And so the committee recommended that the Director General should call also upon the UN Secretary General to establish a UN interagency working group on frontier technologies to facilitate global dialogue and produce a report, for instance, outlining the implication of innovative technologies, including human genome editing and the ethical frameworks to guide their application. And it also recommended that WHO should develop models of best practices for inclusive, multi-directional, multi-stakeholder dialogue and decision-making process that can be applied to human genome editing. So that was my last slide. With this, I would like to acknowledge Catherine Littler, who's the lead on this project and who is also co-lead on global health ethics and governance research unit, which is part of the science division at WHO. And I would like to also to again thank you all for your attention and also for this opportunity to be with you today and for your kind invitation. Thank you very much. Over, back to you.
Thank you very much, Emmanuel, and I apologize for the confusion, but please stay with us, Emmanuel, for the panel discussion. So we're keeping all the questions. Hopefully, participants are writing their comments in the Q&A or in the chat box. So hopefully, we'll get some good discussion. Thank you for this presentation, and now we'll go back to Fiza. So Fiza Akbar is going to give us a presentation about the advances in genomic challenges of genetic counseling in Pakistan. So if Fiza is around, she's on your side or she's online?
I'm here. Yes, I'm here.
You're here. So I will introduce you again quickly because we still have some half a minute. So Fiza is a senior instructor at the Division of Women and Child Health at the Aga Khan University, Karachi, and she holds an undergraduate degree in biotechnology and psychology from Forman Christian College, Lahore, followed by a master from University of Manchester in genetic medicine. So go ahead, Fiza, the floor is yours.
Thank you very much, Dr. Niveen, for the kind introduction. And thank you very much, Dr. Ahmed Jafri and the CBEC team for the kind invitation today. So that's the topic that I'm going to talk about today. I've got no disclosures, and I'll be trying to define genetic counseling, understanding different settings and goals of genetic counseling, and then coming towards the challenges and opportunities of genetic counseling in a Pakistani context. So to begin with, let's just briefly go into a brief history of how genetic counseling started as a profession. So the practice of advising people about hereditary traits began back in the 20th century after a biologist from England actually suggested that the new medical study of understanding the hereditary traits should be called genetics. It wasn't until 1947 that the term of genetic counseling was defined by Sheldon Clark Reed, who was also a biologist. The first formal definition of genetic counseling, however, was published in 1975 by the American Society of Human Genetics, and the most updated definition of genetic counseling came back in 2006 by the National Society of Genetic Counselors, which defines genetic counseling as a profession or a process of helping people understand and adapt to the medical, psychological, and familial implications of genetic contributions to disease. The process primarily integrates three key aspects, which is interpretation of family and medical histories to assess the chances of disease occurrence or reoccurrence, education about inheritance testing, management, prevention, resources and research, and counseling to promote informed choices and adaptation to the risk or condition. And that is a key aspect of genetic counseling to ensure autonomy of decision-making and giving them, the families, that ability to make their own decisions after giving them all the information that is required for them to make those decisions. So being earnest is actually what really brings together all the aspects of genetic counseling, which includes truthfulness, communicative, being unbiased in what information you are giving. That also brings about the fact that my personal opinions about different aspects of genetics should not intervene the way I counsel a family. Accountability, honesty, reliability, all of these aspects then come together for us to actually be good at our job at genetic counseling. And genetic counselors do not work alone. They are part of a task force of human genetics and genomics, which include working along with medical geneticists, laboratory geneticists, and non-genetics health providers. So it's a multidisciplinary team approach that brings in all of these specialists together to make sure that an optimal healthcare is given to the patient that we are talking about. So genetic counselors then can be present in different settings. And while they could be different settings, including clinical settings, research settings, and education settings, we'll be focusing more about the roles of genetic counselors in clinical settings, and they may include predominantly them integrated into clinics of cardiovascular diseases, prenatal genetics, perinatal genetics, pediatric neurology, pharmacogenomics, metabolic diseases, and oncology genetics. So these are some subspecialties that genetic counselors world across would work in. So why is it important for us to integrate genetics and genomics in clinical practice? So at large, these are the four main aspects why we feel that genetics and genomics is essential to become a part of clinical healthcare. It ends the diagnostic odyssey for a family, because the family sometimes are visiting multiple doctors without getting a diagnosis. So now they get an answer about what is happening to their child, for example. It helps to offer them disease prognosis and tailored management so that the family knows what to expect out of a disease of their child, for instance. In the cultural context of Pakistan, and as we started off talking about with the cultural preference of marrying within the families, this then becomes very pertinent to identify carriers for autosomal recessive disorders, to then also inform these families about preventive measures so that the disease does not reoccur in their future children. Now that we are also talking about a lot of advances in precision and genomic medicine, so this also opens up the avenue of talking about possibility for these patients to be enrolled in different clinical trials and be able to get targeted treatments and drug therapies sooner or later. So informed reproductive decision-making, again, is one of the main key aspects of genetic counseling in our resource-limited settings, because as we say that treatment may also be present, but this may not be a present solution for most of our patients in Pakistan. So prevention, again, becomes the key aspect of genetic counseling and incorporation of genetics in clinical practice. So once we know that a couple is a carrier, we can then offer them pre-conception, pre-implantation genetic testing if they want to go in with IVF pregnancy, or if they want to naturally go and go ahead with the pregnancy, then you can offer them prenatal genetic testing. So there are multiple steps in genetic counseling which ensure that all these aspects are covered when we are talking to a family in a genetics clinic. It involves the psychological aspect of a genetic diagnosis, the notification and informing the relatives regarding a genetic diagnosis in a family, characterization of the disease, age of onset, penetrance, all of these informations, types and inheritance risk, what is the reoccurrence in the future, and the possible result outcomes are to be discussed and talked about before the family actually is consented to go for a genetic test. So genetic testing consultations are divided across many sessions, and they are themed around pre and post-test genetic counseling. So it is very important to actually ensure that the patient or the family has been counseled before they actually do a test. So in a pre-genetic test counseling session, it's important for us to take a complete family and medical history, verify all the medical information where it's applicable, assess genetic risk, mode of inheritance, delayed onsets, gene penetrance, and expressivity concepts, so that the family understands that if someone tests positive who actually doesn't have a disease right now, what is their chance to actually have a disease later on, because in some situations they are at 100% risk of then having a disease. In other cases, there might just be a 20% risk of them to have a disease, even if they test positive. So these concepts are to be talked about in a layman's language before a family goes in for a genetic test. And then we talk about result implications, the outcome possibilities, providing the opportunities for families to ask questions. So that is one thing we really need to focus on, for them to ask questions. Sometimes the families would just want you to order the test for them, but it is our responsibility for them, our responsibility to make sure that they are comfortable with what information we are giving them, and they understand it. And if they don't, they ask questions, so that we go an extra mile and do our job properly to make them understand what this conversation is all about. And then obviously taking consent and sharing their genetic test reports and results with relevant healthcare providers in future. Okay, so the slide isn't moving for some reason. That says pre, this says post. No. Okay. So once the results are back, we see the patients back for giving them the results and post-test counseling sessions, explaining what the result means in present for them and in the long term. We also provide them the emotional support after the diagnosis. And it is also important for us to make sure that we have to contain the session in a way that we, again, as genetic counselors, we do not provide them intervention or therapeutic therapy. So we are not registered psychologists. So what we need to do is we need to provide them the emotional support for them to understand the genetics and the diagnosis and the emotional aspect of it. Yet if they require more support, we then guide them towards, seeing a therapist or a psychologist to get more help if they require that kind of help. Explaining the result implications for relatives and the risk of them for having the disease, and then offering familial screening for relatives, so that we identify other family members who may be at risk of developing the same disease. This then enables us to actually establish a long-term relationship with families, with not only individuals, but families, for seeing them back for follow-ups, ensuring that we have the most updated information for their clinical surveillance and management. So it's stuck again. Okay, then we also need to make sure that we are not leaving them with just a result. We need to guide them to see subspecialists who will then take care of them in a holistic approach. And then that would require different subspecialty doctors, making sure that they are getting taken care of optimally. So inside a genetics consultation, there are a few things that we really need to ensure that we are doing correctly. We need to make sure that we are breaking down the concepts of genetics and in a simpler, non-technical language for the patients to understand. So how the disease is inherited, what mode it follows, the age of onset, etc., as we talked about, and then preparing them for the possible result outcomes. In the era that we live in, genetics and genetic testing approaches are constantly evolving. So sometimes they might have an inconclusive result at this point in time, but that may change with time. So we need to also make sure that they understand that this may be an inconclusive result today, but this may change as we test them again in future. Effective communication remains the key. We need to make sure that the information we are giving out is non-directive and non-judgmental. We need to ensure that we aim to provide the information to help them make their own decisions. However, we do not discriminate who gets what kind of information. We give all the information that we have. And we make sure that then they understand the information we are trying to convey, to ensure that the patient has the autonomy to take the next course of actions for not only themselves, but also their families. So here's an example that will try to bring together all the aspects of genetic counseling principles. We saw an individual, she is a 26-year-old doctor herself. She was referred in the genetics clinic by a cardiologist who was diagnosed with long QT syndrome clinically and had a pacemaker inserted because she was, okay, so I think something is really up with this. I didn't do anything. Now it works. Okay, so yeah. So she was clinically diagnosed with it, and she collapsed while she was doing a PCR on a patient of herself. Yeah. CPR. So now that, yeah, so when a biologist go into a clinical, she kind of, then the PCR is my default setting. Sorry about that. So I don't know again why this is happening. This is not the slide that I am seeing here. Can we do that?
Give us 5 minutes, give us 2 minutes while we work out this technological glitch.
So yeah, so while we are making sure that the technical glitch takes care of, I'll just go on and talk about the case. So this lady was then diagnosed with a hereditary arrhythmia disease, which is long QT syndrome. She was actually expecting while she had her genetic testing done, and she was really concerned about passing this on to her child. However, we talked about prenatal diagnosis. The couple did not want to go ahead with it and make the termination based on this arrhythmia diagnosis. So we did not force them towards going ahead with a prenatal diagnosis. However, we made sure what we could do in our ability. So we included a neonatologist, the pediatric cardiologist, and the OBGYN on board, making sure that they understand what the situation is and to be taken care of as a high-risk pregnancy, so that once the baby is delivered, we take care of the things. And even if the family opted out of genetic testing, we ensure that they are optimally taken care of, making sure that we respect their decisions as parents who did not want to go in for a prenatal genetic diagnosis. Again, this had implications for her siblings as well. So there were few of her siblings who were asymptomatic, but then when we offered them cascade screening, they were also identified to have been carrying the same gene, which was KCNQ1 associated autosomal recessive, autosomal dominant long QT syndrome. So they were then consented for testing and then referred for cardiology referral so that they can be taken care of before they become symptomatic. Then I would like to move on towards another case that brings into light the genetic counseling in an oncology genetics setting. So this was a 67-year-old lady with bilateral breast cancer. Her father passed away with the diagnosis of prostate cancer. It was back in 1992 when she had the first diagnosis of left breast cancer when she was just 40 years of age. She underwent her treatment, did breast conservation back in the days. Then it was again in 2009 when she was diagnosed with right-sided breast cancer, underwent a mastectomy followed by her treatment completion. Again, after 10 years, she had a diagnosis of left breast cancer, where she had a conservation about 30 years ago. And this was now the first time that she was seeing a genetics, was referred by her surgeon and oncologist to the genetics clinic. Not to be surprised, she was making a very strong case for this to be hereditary cancer. And when we tested her, she tested positive for a pathogenic variant in BRCA2, which would give us answers that why she was repeatedly getting the diagnosis. So this time around, she had been in and out of the clinics for 30 years, being treated for breast cancer thrice in her lifetime. She said she was very lucky that she was taken care of by amazing doctors who made sure that she was treated in time. She was picked up, the disease was picked up in time, but she did not want to come again for the fourth time. So this time she went into having a complete mastectomy on the side where she had an active disease. And also when we counseled her about the risk of ovarian cancer, she went ahead for a risk-reducing bilateral oophorectomy. We also then identified that there were 3 children that she had. Out of the 3 children, only 1 consented for testing, and she got testing for the familial variant. And luckily, she tested negative, so she did not require all the surveillance that we would offer to someone who is BRCA 1 or 2 positive and requires high-risk surveillance for their risk of developing breast and ovarian cancer. Now I would want to come down to some cultural challenges of genetic counseling. And during this conversation, I would want to delve into a few of these challenges in a greater depth that will include my routine conversations with the families and the patients. So as we talked about the fact that understanding the idea of being carriers is really tough. Blame game happens, which starts with, we live in a patriarchal society, so blaming the woman for giving birth to a child with disorder is the most common thing that we see. So that becomes, this makes it challenging for us to counsel them, as well as puts a lot of responsibility on our shoulders, so that we make sure that this is not affecting families and harming individuals. However, that makes it more challenging for us to actually counsel for X-linked diseases, because then they are passed on from healthy mothers to only their sons. There's a lot of stigma of carrying the bad genes. People are not open to the idea of alternative reproductive options such as adoption, for example. They most of the time struggle between understanding having a prenatal diagnosis versus a treatment.